Well, again, thank you to the organizers. This is really a privilege to talk about something that I enjoy doing and to talk to a crowd that's tuned in at this hour because they obviously enjoy hearing about this and learning about it. So thank you again for having me. I watched Dr. Johnson's talk from last week on the basics of carotid disease. So I'm going to try not to repeat the things that he went through, but there's certain things in carotid disease that just need to be reinforced. It's one of the few fields within neurosurgery that we have really good level 1 evidence for what to do. So a lot of what I'll be talking about in these cases and in the management is using the evidence to treat carotid artery disease the way that it's shown that it should be. So really quickly, my talk tonight is not going to focus on medical management, but just to lay the background. People with carotid artery disease are treated with aspirin. This is an antiplatelet agent, and many can argue whether it should be 325 or 81. Stroke prevention, it's usually 1 dose of 325 and then maintain on 81. But I think either dose is reasonable in the setting of carotid disease. That goes along with aggressive treatment of vascular risk factors. And this is something that I'll mention when the studies were performed that looked at endarterectomy and medical management. We didn't have statins. We didn't have good blood pressure control like this. So the medical management has really evolved over time. Lifestyle modifications are very important as well. Weight modifications, smoking cessation, excessive alcohol, cutting down on alcohol, and a heart healthy diet, which now the one that's being promoted is a Mediterranean diet. So that's medical management. That's what all patients with carotid artery disease should get at a bare minimum. But I'm here to talk to you tonight about what we can do surgically and endovascularly to help these patients. So I know Dr. Johnson reviewed these, but this is how we base all our decisions. So for symptomatic carotid artery disease, the one trial that everybody should know is called the NASIT trial, the North American Symptomatic Carotid Endarterectomy trial. Basically, what this study showed is if you have a patient that had a symptomatic stroke, that's a clinical symptom, and a 70 to 99% stenosis on the ipsilateral side, that patient will benefit from a carotid endarterectomy over medical management, which at the time was aspirin. So the benefit of this treatment is at about a 2-year inflection point. So patients that have a very short life expectancy, this is not the procedure that they need. This is a preventative procedure to prevent further strokes after the patient has had a stroke. There's also a more modest, but still significant reduction in carotid endarterectomy versus medical management in those patients with 50 to 70% stenosis. It's a little more restricted category. Usually the patients we operate on between 50 and 70% are higher risk, often males, because that's a higher risk feature. Often patients who have had strokes rather than TIAs, and hemispheric injuries, stroke, rather than eye findings, monocular blindness, or amaurosis fugax. And that's based on the NASIT trial study. In those studies, the overall perioperative stroke and death rate for a carotid endarterectomy was just shy of 6%. So that's what has to beat the natural history. I mentioned the European Carotid Surgery Trial, very similar trial, but in Europe they used a greater than 80% stenosis and found the same type of results. So I'm going to quickly move to asymptomatic carotid disease. You can imagine that if somebody doesn't have symptoms, there's a greater bar that you have to meet in order to do surgery. In other words, these patients are going to do better without surgery than the symptomatic patients would. So the ACAS study, the asymptomatic carotid atherosclerosis study, showed that the 5-year incidence of stroke or death is substantially decreased for patients that got carotid endarterectomy versus those on maximal medical therapy. And for some reason, this trial was arranged such that the cutoff was 60%. So I already spoke about the 70% cutoff in symptomatic patients, went down to 50% in certain groups. This trial was run at a 60% stenosis. The degree of benefit was substantially less. So the 5-year stroke rate was 11% on medical therapy, where in the symptomatic group, it was in the 20%. And the carotid endarterectomy patients brought down to a 5%. The benefit, again, was predominantly in men in this study. So what does this mean? Well, at this point, the American Heart Association recommends any patient with symptomatic stenosis, that means a symptom from ipsilateral brain to the side of their carotid stenosis, and a carotid stenosis 70 to 99%, they should get a carotid endarterectomy as long as that procedure can be done with a less than 6% morbidity and mortality. Likewise, for asymptomatic patients, they should get a carotid endarterectomy if they have a 60 to 99% stenosis, if the perioperative risk of stroke and death from that procedure is less than 3%. So in other words, if for some reason either patient factors or surgeon factors are not able to meet those 6% and 3% perioperative morbidity and mortality, the procedure should not be done. Now you'll notice all these ranges where we operate is up to 99%. The reason that is because once you get 100% and the artery is completely occluded, there is not good data that it should be opened up with a carotid endarterectomy or a stenting procedure for that matter. It should be left closed and managed in other ways that we won't speak to in this talk. Now you'll also notice that those studies were all carotid endarterectomy studies. They were not stenting studies. I'll get to that later. Stents were not widely in use at the time of those studies. So we base our data off of those carotid endarterectomy studies, but I will bring you up to speed with the stenting studies as well. What I wanted to talk about first is how do we measure these? I'm talking about 50% stenosis, 70% stenosis. Well, there's several ways. The most common that I've seen here in the United States is the NASCET measurements. I already quoted the NASCET study, NASCET. They had a way of measuring the carotid stenosis in their study where you can see in this diagram, I don't know if you can see my arrow, but what they do is they take the distal carotid artery where it's normal, they subtract the lumen that's opened, and they divide that by the distal carotid that's normal. So in other words, you're taking the difference in those two measurements over the normal diameter and multiplying it by 100. Then you get a percent stenosis. The European carotid study trial that I mentioned, carotid surgery trial that I mentioned, they measure a little differently. They still take the area that's stenosed, but instead of putting it over the denominator of the normal distal artery, they look at the normal artery if it did not have a plaque. So you could see that's usually a little bigger. So the stenosis rates are a little different. And finally, the common carotid artery method takes the common carotid artery, which is D here, and takes this percent stenosis over that denominator. So these are all just different ways of speaking the language and being on the same page. And I will tell you that radiologists will actually report it. They will say 70% stenotic according to NASCET criteria. So now you'll hopefully know what they're talking about when you read those reports. So here's a case, a very common case, a relatively straightforward case. A 61-year-old male, otherwise healthy, 4 days history of left-sided weakness, so that's left arm and leg, and numbness, and it resolved 1 day prior to admission. The patient came to our hospital on aspirin and heparin. So the important parts about this case are, first off, whether the stroke resolved or not, the patient had a stroke. We've determined in this case that it's a stroke, not a TIA, because you can see the MRI shows evidence of a stroke on the picture below. And the left-sided weakness corresponds to that right-sided stroke, contralateral. You can also see on the MR angiogram here that there's a severe stenosis of the internal carotid artery. We know that it's not completely occluded because it's filling distal. So this is an ideal candidate for a carotid endarterectomy. It's not clear whether this was based on embolic stroke, meaning a piece of the carotid plaque came off and went into the brain, or a flow-related stroke where either the vessel closed for a little while or the patient was dehydrated and they just didn't get enough blood flow to the brain. Either way, it caused a stroke and it should be treated. So here's what a carotid endarterectomy looks like. And I show these pictures so we can point out a few things. The blue vessel loop here is on the common carotid artery. That's towards the heart. The head is up on the other side. The other blue vessel loop is on the external carotid artery. and the yellow vessel loops on the internal carotid artery. You can see a suture, a ligature, around the superior thyroid artery. That's usually the only external carotid artery branch that we see in our field, but it's important to close that off because when we open the carotid artery, we don't want back bleeding from that vessel into the carotid artery. If you look down in the picture, you see the vessel opened. The vessel gets opened after it's cross-clamped. So what we do is we put clamps on the internal carotid artery, the common carotid artery, and the external carotid artery so that we eliminate flow. And we do it in that order. It's very important to have the internal carotid artery clamped first so that when you're clamping the other arteries, if God forbid a piece of plaque came off, it doesn't go up the internal carotid artery. So that's why we have the yellow band on that. We know what's what. We then make an incision with the artery clamped from about here in the common carotid artery up the internal carotid artery to about here. And you can see that we made a marking on it that we didn't quite go up to the top. And then you see we're taking an instrument and dissecting this plaque out of the carotid artery. We take it out of the internal carotid artery, we take a piece out of the external carotid artery and out of the common carotid artery. It can either come out as one piece. I often like to cut it into two pieces so it's easier to maneuver. And then when we're done with that, we suture the vessel back up and we open the clamps in the reverse order. I didn't mention the superior thyroid artery, but that's actually tied at the beginning of the case. We don't worry about when we have to tie that off or when we don't, because all the other vessels are patent. So the way I do this is I put a tie on the superior thyroid artery that I'm going to cut at the end of the case. I'm going to cut the tie off. Then I clamp the internal carotid artery, the common carotid artery, the external carotid artery, take out the plaque, open the arteries in reverse, and then cut the tie off the superior thyroid artery. You'll remember that the superior thyroid artery is the first branch off the carotid artery. And if you have bleeding when you've clamped off the three big vessels, you open your field and you still see blood, it's likely either coming back in through the superior thyroid artery or the second artery that is behind the carotid, you can't see it in this picture, called the ascending pharyngeal artery. So sometimes you need to look for that artery in the back. It's very rare, but if you don't put a clamp across that or close that off in some way temporarily, you could have back bleeding into your carotid artery. The other way you could have back bleeding is if your clip, we use an aneurysm clip or clamp on the internal carotid artery, isn't high enough and you clip down on the plaque. The plaque will not close properly and you'll see back bleeding into the carotid artery. So that's a good sign that you know you haven't gone high enough. Now, the way to know you're high enough is you can palpate the plaque. You can feel the carotid artery is hard where the plaque is, and then it softens up above. You don't want to feel too hard because you could dislodge some of the plaque. So those are the important steps and what I think about in this procedure in a straightforward manner. Now, I'll talk about on the next slide. Some people do this awake, some people do it asleep. Some people do it with monitoring of motor evoked potentials and sensory evoked potentials. Obviously, you don't do that if the patient's awake. I'll talk about the advantages and disadvantages to that. So, importantly, preoperatively, this is one of the rare neurosurgical procedures that we do not hold aspirin on our patients. So the patient maintains his aspirin throughout the procedure. We don't hold it 5 days before surgery. We don't hold it 7 days before surgery. That's important. I also maintain heparin until the patient's in the OR. I don't hold it 6 hours in advance. I just let the heparin run until the patient goes into the operating room. Now, I do these asleep under general anesthesia, but many people do them awake. I do motor evoked potentials and sensory evoked potentials, so I know without the patient awake, when I put those clamps on, whether the brain is getting enough blood or not. And if the brain's not getting enough blood, I can put in a shunt, which is a small tube that goes from the internal carotid artery to the common carotid artery to the internal carotid artery, through, around, or outside of the plaque to allow the blood to go through into the artery and not have the brain deprived of blood. Other people do shunts in every case, so they don't have to worry about that. I selectively shunt, meaning if the potentials drop, that's when I shunt. As I mentioned, I use motor evoked potentials and sensory evoked potentials. Other people use EEG with TCD. Either way, you can see if the brain's getting enough blood. I mentioned heparin. We give heparin during these procedures. That's why it's not critical to turn any heparin off before. There's a study that shows you can dose heparin according to the weight of the patient, or you can typically just give 5,000 units intravenous. You give heparin right when you cross clamp the artery. When you cross clamp the artery on the internal carotid artery and the common, there's no longer any flow, and the blood above and below those cross clamps, especially above, can develop stasis and develop clots. So that's why we give heparin when we cross clamp the carotid arteries. The other thing we do when we cross clamp the carotid arteries is we induce hypertension. I like to see the patient's blood pressure 10 points above their systolic, so that we know that if there's any decrease in blood flow on that side of the brain, at least they can get more blood through the ACOM, through the posterior communicating artery, or across collaterals on the top of the brain. So we induce hypertension. So I mentioned some of the critical portions of this case, but this is the relevant anatomical structures. You open the platysma, you go down through the sternocleidomastoid, you push it to the side, but that's the level you're at. Then you see the jugular vein and the carotid artery. There's usually a vein called the transverse facial vein that is crossing right across your carotid artery, and that's taken, that's sutured and cut, coagulated and cut so that you can get down to the level of the carotid artery. You then see the carotid sheath. The vagus nerve is usually under the vessels. Cranial nerve 12 runs at the top of your field. Those are important structures to look out for and to avoid. I mentioned the cross-clamping order is very important. The internal first to protect it from any debris, then the common and the external. Obviously, if you have any debris going up any of those arteries, you want it to be the external to the face and to the scalp. We mentioned the relevant other vascular structures that could give back bleeding into the carotid artery bed, which is the superior thyroid artery and the ascending pharyngeal artery. So we've talked about carotid endarterectomy, and that's been around the longest for these procedures, but then came carotid artery angioplasty and stenting. The reason this happened, as I mentioned, you want to keep your perioperative morbidity for these procedures low, and there are certain patients that are just poor operative candidates on the basis of either their anatomy or their clinical condition, and this is where carotid artery stenting, angioplasty and stenting really is a great procedure. So these are what stents look like. Some of them are what we call open cell, and some of them are what we call closed cell. The closed cell ones have all the links connect with each other, and the open cell ones have some missing links, like up on top. So there's more bendability. Some people would say it's easier to navigate the open link ones because they turn better, and some people would say the closed link ones maybe keep the plaque against the wall a little better because there's less holes in them. I don't know that either of those have ever been shown, but that's what people talk about. You can see an open cell one on the left, and you can see a closed cell one on the right, and you can see that their cell areas are all different. Different stents have different holes in terms of how big they are and how open they are. So you have to consider that when you're putting in a stent in the carotid artery. Embolic protection is critical. So these procedures need to be done with embolic protection. That could either be a filter, which catches debris up north of the carotid plaque. People used to use a distal balloon. That's not used as much anymore. Or a proximal balloon, or several proximal balloons on a device that can block off the common carotid artery and the external carotid artery. If you arrest flow, you've done distal protection without putting anything distal. You see pictures of each of those below. These are what some of the different filter baskets look like. All the different companies have them. Basically, the filter basket lets blood flow through, but catches debris, and that's what you want in these types of procedures. What's nice is you do not have to arrest flow like you do in a carotid endarterectomy case. When you cross clamp, you can let flow continue. So this whole thing started with stenting for high-risk patients. There was a study called the Sapphire study, which was stenting and angioplasty with protection in high-risk patients for endarterectomy, that enrolled patients that were high risk for surgery, only patients that were high risk for surgery. And we'll go over what those criteria are. The primary endpoint, which for most of these studies is death, ipsilateral stroke, or MI at 30 days, was significantly lower in the stenting group, 12%, versus the endarterectomy group, 20%. So this showed in patients that were high risk for carotid endarterectomy, stenting was probably a better option, and that makes sense. So at that point, the FDA recommended approval for a specific stent, the Cordis Precise stent and AngioGuard. That's the specific embolic protection device in symptomatic patients, only symptomatic, at high risk for CEA. So they had to be high risk patients. Following Sapphire, most companies did a registry or multi-center registries to show that their device could also be used in this realm. And this is how all the different devices have been approved for carotid artery stenting. Based on these trials and registries, CMS, that's Medicare, approved carotid artery stenting with distal embolic protection. So you have to use distal embolic protection for patients who came in to the procedure good grade. The modified Rankin means they're functional at grades 1 and 2. They are high risk, and we'll go over that. That doesn't mean a tight stenosis. That means a high risk either anatomically or clinically, and had to have a stenosis greater than 70%. If they had a stenosis 50 to 70%, they could be enrolled in a study. And if they were asymptomatic and had 80% stenosis, they could be enrolled in a study, but they could not be treated by CMS, the Medicare criteria, sorry. So what is high risk for carotid artery endarterectomy? So a patient with bad congestive heart failure, a low ejection fraction, unstable angina. If they have their other carotid artery occluded, because then when you arrest flow, it becomes more dependent on your shunt and less dependent on your other carotid artery. Now, there's plenty of people who will still do an endarterectomy with a contralateral occlusion. We call this a relative contraindication or a relative high risk. If someone's had a recent MI, those are all the medical types of things aside from the occlusion. Then there's anatomic things. If you had a previous carotid endarterectomy, the tissue is scarred. If you have radiation to the neck, the tissue is scarred. And anything else that makes it difficult for the surgeon anatomically could be considered high risk and allow you to do stenting. So here's a case of a stented patient. This was a 45-year-old patient who had radiation to the neck and developed this carotid narrowing. And as you can see here, it's very narrow and it's very irregular. That's not how carotid arteries look when they just develop plaque. That's probably radiation is involved there. You can see on the x-ray, the patient actually has a stent on the other side. And what you can see on the right is the intracranial circulation filling on the angiogram. And as long as you can see my picture, I'm going to draw your attention to the fact that the anterior cerebral artery is not filling, only the middle cerebral artery. From this picture, we assume that the anterior cerebral artery is filling from the other side. So this patient underwent carotid artery angioplasty and stenting. You could see the filter basket on the left placed up at the top of the internal carotid artery. Balloon dilatation opens up the carotid so that you can get your stent through. We put a little balloon in there. Then we push our stent through and we open the stent. And you can see in the picture on the right, it's no longer irregular and there's good flow through the carotid artery. This is what we saw in the filter basket, I think of this case, but certainly in one of our cases. And you know that you're glad that you had it up there because that would have gone to the brain otherwise. Here's the post-operative images. I already showed you this, pre-op, post-op on the left. But what's interesting here is when you shoot this preoperatively, you fill the middle cerebral artery, but not the anterior cerebral artery, getting flow from the other side. When you shoot it post-operatively, you fill both vessels. That's because this is much stronger filling after you've opened it up. So that helps the patient out substantially. So pearls and issues in carotid angioplasty and stenting procedures. Angiographically and anatomically, the bifurcation on average is typically about the C4 level. The internal carotid artery comes off posteriorly to the external. That's on a lateral angiogram. And on an AP angiogram, the carotid artery comes out lateral to the external carotid artery. It then swings medial to get to the skull base. They cross over one another. You have to have sufficient distance between where your stent is going to land and that little filter basket is, because the last thing you want to do is get that filter basket entangled on the stent. That filter basket is going to come out at the end of the case. You got to be able to pull it out. And we can balloon dilate the vessel before stenting or after stenting. I usually dilate a small amount before stenting just to be able to get my stent up and through the stenosis. And then once my stent is in, protecting the plaque against the wall, I've crushed the plaque up against the wall, then I'll balloon dilate afterwards without any fear of my clot fragmenting off and going north. As I showed in the angiogram, you get increased flow after the procedure, and you get what we call a shift of the watershed zone, meaning instead of the distal reaches of the artery being very close to where, where it takes off at the bifurcation of the middle cerebral artery, anterior cerebral artery, it shifts back to a normal position between the two arteries. It's not further towards the MCA or the ACA. Now, when you have a flow-related stroke, it's usually what we call a watershed stroke. It's right in between the middle cerebral artery and the anterior cerebral artery in the brain if you have a normal anatomic structure. So after carotid artery angioplasty and stenting, I maintain dual antiplatelets for 6 months. And then after 6 months, I stop the Plavix or Prasugrel, the heavier one, whatever it is, and I maintain aspirin indefinitely. Carotid endarterectomy patients, I also maintain aspirin indefinitely. All patients, stenting or endarterectomy that I do, get an ultrasound at 1 month to look for early vessel patency, and then get yearly Dopplers from then on out to look not just at the artery that we've treated, but also in the artery that we haven't treated, because these vasculopaths tend to get bilateral disease. So, carotid revascularization endarterectomy stent versus stent trial called the Crest Trial. This was a big study that compared carotid endarterectomy and stenting, and many thought that this was going to be the trial that brought stenting completely mainstream, and we would be able to lift the high risk criteria for stenting. It enrolled over 1,000 patients symptomatic and over 1,000 patients asymptomatic, and it was patients over 50% for symptomatic, just for the reasons I told you before, and 60% for asymptomatic. The endpoints were the same ones we've spoken about: death, stroke, myocardial infarction. Now, somewhat interestingly, there was no significant difference between the two treatments. So those who did carotid endarterectomy were happy with that. Those who did stenting were happy with that. They were both obviously good results. What was interesting is the strokes were higher in the stenting group, and the MIs were higher in the endarterectomy group. We can get into the nuances of that and how they were measured differently and why that might affect people's biases. Obviously, cranial nerve palsies were more common in the endarterectomy group because you're opening the neck. More interestingly, perhaps, is young patients did better with stenting and older patients did better with endarterectomy. That's completely counterintuitive to what we believed, because we thought the high-risk patients were the older ones. So what that basically did is it made people really consider what procedure for what patient, and it did not change the CMS criteria for any of this, but I would definitely say it had more people operating and doing stents than were doing so before the Crest trial. But I would argue that they're both good treatments, and a lot of people would say, I'd rather have a change on my EKG, which is how they measured myocardial infarctions, than a stroke, and therefore maybe carotid endarterectomy was more favorable in this trial. It's yet to be determined. So, based on my practice, based on the data, based on my colleagues, which patients should not have a carotid endarterectomy? Which patients should get stenting? Now, having heard this talk, I hope you can answer this question to some degree. It's those high-risk patients, patients with CHF, MI, angina, pulmonary disease. Importantly, radiation, recurrent stenosis after endarterectomy. If the lesion is either high above C2, then the mandible gets in the way of your procedure, or low below T1, the clavicle. You don't want to be cutting bones to do a carotid endarterectomy procedure. You don't want to be struggling below them. So those are good for stenting. Age greater than 80, maybe, we said that. Contralateral occlusion, relative indication. Which patients should not have carotid artery stenting? Who's better for carotid endarterectomy? And I'll tell you right now, carotid endarterectomy is the default. If you don't have a reason not to, that's the procedure to do. But here's the patients that are not good for stenting. If they can't be on dual antiplatelets, remember, endarterectomy patients have to be on aspirin. Stenting patients have to be on dual antiplatelets. If they have severe renal impairment, an angiogram is going to hurt them. If they have terrible vessels like the ones I showed before, and you have difficulty where it puts them in danger trying to get to the lesion, those are not good for stenting. Heavily calcified plaque, sometimes it's hard to do the balloon and crush that plaque, although I think that's a relative contraindication as well. And if you have intraluminal thrombus, people do it. You could suction an intraluminal thrombus out. That's a floating thrombus in the carotid artery. But others, myself included, feel a little more comfortable clamping the carotid artery in the operating room to know that a loose thrombus that's sitting in the middle of the vessel won't go north when you're operating. So this brings us to our study that's currently going on called the Crest 2 study. And remember, Crest study compared carotid endarterectomy and carotid artery angioplasty and stenting. The Crest 2 trial compares each of those in their own arm to medical management. We haven't talked a lot about medical management in this talk, but medical management has improved immensely over the course of the past 30 years or 40 years since these studies were done. So now many would contend that on asymptomatic carotid arteries with severe stenosis, medical management might be better than some of these procedures. Well, that's what this study is going to find out. 70% narrowing, asymptomatic or symptomatic, parallel study design, medical management versus endarterectomy, medical management versus stenting. So far, 1,715 patients out of 2,480, and I think that's up to date, have been enrolled. So we don't have results yet, but we're all looking forward to these results. Hopefully it'll clarify some of those questions. And I wanted to just draw your attention to another procedure called the TCAR procedure, transcarotid artery revascularization. And now, remember from the Crest study, we were worried about the strokes in the endarterectomy, in the stenting patients. So many have argued that getting up to the carotid artery through the other vessels and through the aortic arch may be dangerous to the patient. So this tries to obviate the need for this. So what the TCAR procedure does is it works through a small clavicular incision, and it sets up a flow arrest or reversal so that there's no forward flow through the artery during the time of the procedure. And you directly access into the carotid sheath through the carotid artery, and then you deploy a stent. So you don't have to do the dissection for a carotid endarterectomy. We don't have to worry as much as whether it's high or a low lesion. I guess low would matter, but we don't open the carotid artery. We put a stent in through a surgical incision. So this is great for vascular surgeons or neurosurgeons who, can employ a hybrid approach to do these. This is approved right now for 80% stenosis. It's in studies. It's catching on. I don't know if it'll be the way of the future, but it's certainly a clever and unique way of approaching these.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.